Okay, good morning, everyone. We'll make a start. I always like to try and at least start on time, given that we have a pretty busy agenda to get through today. We are recording and live streaming as always, so that's now up and running. So welcome everyone to what is effectively the first full meeting of our new Performance Audit and Assurance Committee. I've been calling it PAC, so I need to get that acronym straight in my head. This is the first meeting. It is a fairly long agenda. We've grouped things and kind of running things in a way that we think makes sense, but it may not be entirely perfect. So please do bear with us. And if members do have suggestions about how to do things better in the future, kind of always happy to learn as we go and take a kind of iterative approach to running the committee as successfully as possible. Okay, do we have any apologies this morning?
No apologies, Intermediate Chair.
Apologies. Are there any declarations of interest in relation to any of the items on today's agenda? Not seeing anything. Okay, great. Can we move then to the minute of the previous meeting held on 17th of January, which was really our inaugural meeting and election of chairs. Is there anything anyone wants to raise in terms of accuracy from that? Can we accept that as an accurate minute then? Yeah, great, thank you. Moving on to the action log. So the only thing in the action log is to review the terms of reference come September, which we'll do, so no need to get that now. So I'll take us on to item 5, which is the performance monitoring report. I think Callum is going to begin discussion on that. Over to you, Callum.
Thank you, Chair, and good morning, members of the committee. In an effort to streamline our reporting, we've brought the performance monitoring report together with the previously separate complaints and feedback report. At the moment, the complaints and feedback report has been added as an appendix, but we've committed to integrating both reports and we will streamline the presentation for future committee meetings. In the meantime, this morning, I'm going to give an overview of the content of the latest iteration of the performance monitoring report, and then my colleagues Gordon and Ailey will cover the complaints and feedback appendix to the report, and then we'll open up to any questions. So in terms of performance, for this iteration of the report, performance is reported up to December 24 and with a year-on-year comparison. The report has a focus on exception reporting, and I'm now just going to briefly talk through some of the areas that it highlights. The report highlights the position around emergency department 4-hour compliance and around delayed discharges. Compliance against the ED 4-hour access standard was at 44.4% for December 24, and that's compared with 46.1% for the same period the year before. There were 81 delayed discharges at the December 24 census, which is an increase from 73 for the same period last year. The overall position remains under continual review, and in sections 5.1 and 5.2 of the main body of the performance report, which is at page 25 of the packs, you can find some further details as well as some of the actions that are ongoing to support. The report details for both Falkirk Council and NHS services the number of complaints received and the percentage responded to within timescales. For Falkirk Council, there was a total of 113 complaints received in the first 3 quarters of the year, and 72% were responded to within timescales. The report also notes that there has been an increase in the volume of complaints. So in the first 3 quarters, as I've just mentioned, we received 113 complaints, but with the total for the last year was 77. So we are going to see a much bigger total for the full year when we have those figures. For NHS services within the partnership, there were 37 complaints received and 37.8% responded to within timescales. There are also detailed exception reports for sickness absence across both Falkirk Council and NHS services. For Falkirk Council, absence for the first 3 quarters of 24-25 was 10.1%, and that's a decrease in performance from the equivalent period last year when the figure was 9.5%. For NHS services, the overall December 24 sickness absence position is reported as 9.23%, and that's compared with 8.17 in December 23. Lastly, in terms of exception reporting, the latest position for waiting times for psychological therapies. So in December 24, 76% of patients started treatment within 18 weeks of referral. And that's an increase from the previous month's position of 72.6%, but also an increase from the previous year when it was at 74.6% in December 23. I'm now going to pass you over to Gordon and Ailey, who will cover the complaints and feedback appendix report, and then we can open up to any questions. Thank you.
Thank you, Callum. If members wouldn't mind, can I take you to page 49 of your papers, please? That's where the complaints, the detail of the complaints report is. I'll just give you a moment to get there. Good. Okay, so as Callum has already highlighted, I think the big picture story here is the increase in the overall number of complaints. They're up substantially on previous years. We won't have the full year figures, obviously, for another quarter. And the intention is to do a deep dive into the figures at that point to try and establish what are the reasons for this. There are various hypotheses. People could be concerned about obviously timescales, but there may be an increasing awareness. There may be things going on in different service areas. We want to get into the detail of that. At the moment, all I can say is that we've observed there is a significant increase in the number of complaints. In terms of the response timescales for complaints, they're down a little from the last quarter, but we actually have responded to more complaints than they did the previous quarter. So we're trying to keep on top of these. We're trying to keep up to our standards up, but that significant increase is having an impact, and we want to know what that's about and what our services need to do in order to try and respond better, potentially get involved earlier to divert those complaints and resolve those matters before they become complaints. There's a significant drop-off, as you'll see, in the number of complaints responded to in timescale for stage 2 complaints. These are the more complex complaints. There was 4 of them in the quarter, and 2 of them we didn't manage to get to in time. Given the nature of the complaints, that is not, I'm not too concerned about that, but obviously I have raised that with managers. It's something we need to keep on top of. The last thing I'll mention just now is the care opinion information. As we can see on, and I think it's page 62, there have been a number of compliments fed back to the service. I've noted over a number of these reports, there are definitely more coming in for the joint loan equipment store and residential care. Proportionately, why are we seeing more coming in there than we are, for example, with home care and community care teams? There's a lot more interactions in those areas. So try and do a little bit of a dive into that as well, see what we can learn from what these services are doing and how we can encourage other services to direct people to care opinion as well. And I'll hand on to Ailey.
Thanks, Gordon. Sorry, I'm working on one screen. From NHS's perspective, as Callum sort of run through, we have received 37 complaints year to date within the reporting period, with a performance of 37.8%, 50% stage 1 performance and 12% stage 2 performance. Stage 2 performance has been a challenge across the entire Forth Valley organisation from a health perspective. We've managed to increase overall performance to about 25% within probably the sort of later months, so it may be not quite in line with this reporting period. So we'll keep a wee eye and see if Falkirk's manages to pick up in line with that. Of the cases that we have had so far, so there's been 37 year to date, 29 of which have been closed, 23 of those were not upheld. So because of the low numbers, that gives about a 14% upheld ratio, which is higher than the rest of the organisation, still probably slightly lower than we're seeing across national averages. But we've changed some of our sign-off processes to try and get some increased visibility and transparency around that. As we said, so there's the largest challenges that we're facing just now have actually been a long-standing backlog, largely due to absence within the 23-24 year, which has just taken us a long time to pick up on the back of, because it is an exceptionally small team. We are currently carrying one vacancy in the form of a maternity leave for the next 11 months, and we've got one other vacancy. So the team are actually continuing to sort of face a really difficult period. We are trying to work with all available services to see where internal drafting can be carried out, etc., just to try and speed up the process. And we've also got 4 posts out to bank at the minute. In terms of the main themes, it's communication and staff attitude, which is in keeping with the wider organisation that we see. We have changed probably within the last 3 or 4 months our sign-off process. So what we'd realised was that there was actually a bit of a gap in terms of your senior teams seeing the final copies of complaints to really carry out that scrutiny, offer assurance and transparency, and equally accountability in terms of action and changes being undertaken. So we've fixed that now. We might need to have another wee look because there's obviously been some structure changes in Falkirk lately, but other than that, we believe we're now on top of that. So it means that the likes of your lead nurses, etc., will now be involved in that final process for sign-off, which will help us much more efficiently capture if there needs to be any learning carried out, etc. There have been a total of 47 complaints received year to date, mostly just sort of breaking down to thankful for care and treatment, high quality nursing care, etc. as well. So in terms of the good parts, we're still seeing actually more compliments than we are seeing complaints for Falkirk, which is nice to see. Thank you.
Okay, my thanks to Ailey, Gordon and Callum for that. I think it does make sense to combine the 2 reports. It gives us a good overall picture of what's happening in services. Can I open up then to members for questions or comments? Roger?
Thanks. I just wanted to say what was probably the blindingly obvious, which is with all the cutbacks, it's not surprising at times we're struggling to meet the stats where we would want them to be, and not surprising that there's going to be some complaints which are in relation to cutbacks, and I think really staff are trying incredibly hard to do the best they can in the circumstances.
Yep, I think that's a fair comment. Councillor Hannah?
It absolutely is difficult for staff to do it, but I did want to ask, the complaints for NHS Forth Valley is, you said that overall response rate is noted as 36.4%. Is that up or down, and do we have any sense of why? You may have covered it, but I didn't quite catch whether there was an improvement or a deterioration.
Don't worry at all, Councillor. Sorry, I will just put my fingers on the data so that I can tell you exactly. It's just on some earlier files. I can certainly say that performance generally is improving, but I wouldn't want to give you a false steer in terms of Falkirk, because my oversight is more organisation level. Sorry. In fact, just to save time for the committee, I'll feed that back specifically for you. Generally, though, performance has improved. So on an organisation level, performance when I first joined was sitting about 2% for stage 2s. So to have increased that to 25%, which has actually been achieved without any additional staffing within that space and carrying those absences, is small but significant for us. And I'll feed back the specifics for Falkirk just in an email post-meeting so that you've got that from last year's positioning into this year.
Thank you. And in terms of Falkirk Council, there's been a significant increase in the number of complaints. Do we have any sense of whether this is simply because we are encouraging it, which would be a good thing, or because there have been more issues for people to complain about?
Thank you, Councillor. So I think there's probably a bit of both. When I look at the figures over a longer period of time, we go back to even pre-COVID time, there were a a significantly higher number of complaints. At a point, then they dipped during COVID. Now they've come back up again and are above the level that they were pre-COVID. So there's an element in which I'm looking at the numbers, I'm thinking they've increased quite rapidly over the last couple of years. But part of that is, I suppose, going back to what was the longer term kind of level. But I still need to go in and have a look underneath that and see, well, is it because we are encouraging people? The questions that you're asking there, that needs to be part of the analysis that we're doing.
Thank you. I think it is. I mean, the numbers are important, but what's behind those numbers is even more important.
Absolutely. Thank you. Ailey, do you want to come back in?
Thanks both. I guess it's just, and I know we're talking about the council's complaint, but from the NHS's perspective, we've done a bit of a deep dive into that space because we've seen that same pattern, and actually what we've managed to identify is a 21% increase in the number of healthcare interactions that we've seen over the last year. In comparison, not only with sort of the COVID period, but even prior to that, the volume of patients that we're seeing has gone up so significantly that our complaints ratio is still about 0.21% of every interaction. But the volume of interactions has just gone up very, very significantly.
Thanks. Yeah, that's useful to note. So, but percentage-wise, we're still seeing around the same number of complaints relatively. Okay, are there any other questions or comments on this report? Okay, thank you all. We've got one action there in terms of the stats for Falkirk, which we'll circulate to all committee members when we have that. Thank you all for the report. Can I move on then to item 6, the National Audit Report and Inspection Audit Overview. Marie.
Thank you, Chair. This report provides an overview of the National Audit, Scrutiny and Inspection reports published since the last previous Audit Committee meeting held on the 15th of November. A total of 4 national reports have been published since the last meeting by Audit Scotland, 1 by the Care Inspector and 1 fatal accident inquiry determination. As previously requested, the national reports have been circulated to all members with briefings where appropriate. And of the 4 briefings, I'll just highlight a few items. So the first one noted is the Alcohol and Drug Service audit. A number of recommendations have been made in relation to alcohol and drug services to continue to tackle drug and alcohol harm, and these are set out at 4.3 and 4.4 in the report. The Audit Scotland Fiscal Sustainability and Reform in Scotland audit focused on the fiscal position, including the medium-term financial strategy and the Scottish Government's approach to achieving financial sustainability. They have made a number of recommendations to Scottish Government around the approach to public spending and public service delivery models in the findings. Audit Scotland, NHS in Scotland 2024 Finance and Performance. A separate briefing has been issued to all members around this report, and it covers the financial and operational performance of Scotland's NHS in 23-24, and that's summarised in the report at 4.8 through to 4.12. Around inspection reports, these have been set out at section 5, with Thornton Gardens receiving an unannounced inspection which took place on the 14th and 15th of January 25, with no areas of improvement identified, and reports are 5 very good for Thornton Gardens in that regard. A fatal accident inquiry determination was published on the 17th of January in relation to the deaths of Katie Allen and William Brown at Polmont, and there's a separate report later on the agenda today specifically on that topic. I'm happy to take any questions, and there are other colleagues in the room as well around that. Thank you.
Okay, thanks, Marie. Open it up for questions and comments. Pauline.
Thank you. I just thought I might come in there just to highlight that earlier this week Audit Scotland produced its annual finance bulletin concerning the 23-24 performance of IJBs. So it's just very much a recent report that's come out. I'm mindful that it'll appear in your next quarterly meeting, as these papers have. But I think the team that had prepared it were quite keen that it was circulated on a more timely basis, particularly at this time of year when budgets are being set. So just wanted to draw it to your attention. It's a really interesting report, and it takes all the data from all the IGB accounts and the annual audit reports, and produces an analysis of financial performance. A little bit different this year in that it also includes an associated interactive online tool, which is really helpful. Uses lots of infographics and really user-friendly data analysis. So just to bring to your attention, it's available on our website if you've not already seen it, and just would urge you to have a look at it. It does lots of really interesting stuff with comparisons with other IJBs. It explores individual performance, but also national performance, and lets you drill down into some of the more contextual data around about performance, all the national and local factors, population, demographic pressures, looks at different levels of funding, reserves, savings, etc. So just to bring to members' attention at this really important time of the year when budgets are being set, that you might want to have a look at that report. So that was all I wanted to say. I appreciate it will come back to you at a later meeting. Thank you.
Thanks, Pauline. Yeah, I actually read it last night. It's quite a sobering read. I think nothing that was terribly surprising in terms of the financial position of IGBs, but not an easy read. Marie?
Yeah, thanks for highlighting that, Pauline. It was just to say I'll be preparing a briefing on that report anyway and circulating that to members, and I'll also be including some narrative around that in the budget paper, which will come to the IGB as well. Thanks.
Yeah, that'd be very useful. Thank you. Councillor Hannah?
That was an answer to my question. Thank you.
Great, thank you. Okay, any other questions or comments on the national reports? Okay, can we note that report then and move on to item 7, which is the internal audit progress report. Anne-Marie, I think you're going to take us through this one.
Yep, thank you, Chair. So before you, starting on page 72 of our paper pack, is our routine internal audit progress report that the previous audit committee used to receive. Also within the report on this occasion, there are some other updates in terms of explaining the rotation of the Chief Internal Auditor role from the current audit arrangement with the NHS Forth Valley audit team back to the Falkirk Council internal audit team. And there is also an update in terms of the new internal audit standard framework, which is coming into play as at the start of April this year. So just some of the key points that I was wanting to just go over in terms of the report. I'm not going to go into every detail within it, but it's just to emphasise that the 24-25 audit plan will continue to be delivered by ourselves as the Forth Valley audit team by the FTF Internal Audit Consortium, and that because of the rotation this year to the rotation next year for Falkirk Council taking over the audit, that will mean that we need to adapt this year's audit plan to allow us the time to undertake the annual internal audit report, which is crucial in terms of providing that annual assurance from the Chief Internal Auditor to support the governance statement that will appear in your annual report and accounts. The other point just to mention is that going forward, the 25-26 internal audit plan that will be developed by Falkirk Council. So I just want to touch a little bit on the new standard framework that's going to be coming into play as of the start of April. Very much in terms of the arrangements around that, much of what internal audit does won't change to a great deal, but it's important that that work is undertaken by the internal audit services to sort of map what they currently do to the new standards. But fundamentally, it doesn't change anything that's going to happen in terms of the current audit year. So one other thing I was wanting to point out was our ongoing work that we're undertaking is well advanced. That work relates to our internal control evaluation work, and we have our final client meeting next week, and that will allow us to issue our audit findings to the Chief Finance Officer in the very near future. And in terms of the routine part of the progress report that you have before you, Appendix 2 covers off the various partner body audit work that has been completed in recent months, which is of interest to the IGB. That was all I was planning on saying in terms of the progress report and the various pieces of information within it. but happy to take any questions.
Okay, thanks, Anne-Marie. It's useful to know those handover arrangements are in place. Comments, questions? No. Everyone happy with the report? Okay, so recommendations are largely to note, but we do need to approve at 2.5 the amendment of the current year's audit plan to accommodate the completion of the internal audit annual report. We have to approve that and note the remaining items.
Agreed.
Okay, thank you.
Thank you.
Thanks, Anne-Marie. Can we move on to item 8 then, which is the annual audit plan for 24-25, Marie?
Thanks, Chair. We've got Pauline here from Audit Scotland today, so I'll hand over to her just in a second. I suppose I just wanted to highlight to the committee, there's a letter attached just to set out from External Audit that in a similar way to last year, it's likely that our audited accounts won't come until the November committee. So that's very similar to last year's timetable, and Pauline, I'm sure, will cover that with you. But it was just to say that, you know, from my perspective, last year it didn't cause any particular issues, and I just wanted to highlight that before I hand over to Pauline. Thanks.
Okay, over to yourself, Pauline.
Thank you. Good morning. Yes, so the paper I'm bringing to you this morning is our annual audit plan for the 24-25 audit. It's a pretty straightforward report, and members will have seen similar in previous years. I'll just go through a couple of things just to draw to your attention. At paragraph 5 of the plan, we outline the scope of the audit, and members will see there that the scope of our audit for 24-25, as with previous years, is to provide an audit on the annual report and accounts, the financial statements, and also to provide conclusions on the 4 wider scope areas that are covered by public sector audit in Scotland. Just moving on, a couple of things to draw out of the plan. Exhibit 1, which is just at paragraph 12, we highlight the various materiality levels that we apply to our audit work. Very similar to previous years, you'll see there that we have an overall materiality level of £6.1 million. We have a performance materiality of 4.3 million, and a bit of an explanation about what that is. It's essentially a trigger point whereby if during our audit work we identify some errors or misstatements, we would consider whether they breach that 4.3 million level. And if they do, then we would be required to do some additional audit procedures to ensure that we don't breach the overall materiality level of £6.1 million. And finally, our reporting threshold of £240,000. So that's the level at which, if we identify any misstatements beyond that level, we'd be required to report that back to this committee as those charged with governance, and that would come through in our annual audit report at the conclusion of the audits. The next part of the report to bring to your attention is at Exhibit 2. This table outlines the significant risks of material misstatement to the financial statements that we identified as part of our planning and our risk assessment process. You'll see that we only have one significant risk, and that's a standard risk that you'll see in all audit plans. It applies to all of our audits, and it's the risk caused by management's ability to override financial controls, and it just recognises the unique position that management are in. And you'll see there we have a number of planned audit responses that we will carry out throughout the audit, and we will report back in that in our annual audit report. And that work will give us assurance that there hasn't been any instances of management overriding controls. Moving on to the next section of the plan, it covers the wider scope and best value areas, and you'll see there we have the 4 bullet points that outline the 4 areas of wider scope covered by public sector audit. Members will have seen those in previous years, a little bit of an explanation of each of them about what they cover, and again we will consider arrangements for all 4 of those, and we'll report in our annual audit report at the conclusion of the audit. And finally, as was mentioned by the Chief Finance Officer, the timetable and reporting arrangements. And you'll see that I've just noted there that we will not be able to conclude the audit and approve the accounts until after the 30th of September, which is typically the date that we would be working for. And you'll see that we've outlined the timetable that we are planning to work to enable us to sign off the accounts by the 21st of November. And I think included in the pack, there, Appendix 2, there is a letter that I provided to the Chief Finance Officer, just outlining, as in previous years, the reason for that. And it essentially is part of our prioritisation programme, where we're trying to bring back our audits in line with pre-COVID timetables. And as you can understand, we have to do that on a priority basis. So some of the audits that are prioritised are things such as pension funds that have to provide assurances to other bodies such as councils. And then the next level that we are prioritising are councils. So as a appointed auditor for Falkirk Council and Falkirk Pension Fund, those two audits are prioritised this year for me to sign off by the end of September. And then the team will move on to do the IJB. We're looking to, between now and the end of the audit appointment in 27-28, I think, to move back as far as we can to the previous pre-COVID timetable. And each year we expect to see incremental progress towards achieving that. And as the CFO mentioned earlier, last year the audit went smoothly. We're very pleased with the quality of the papers and the accounts that we received, and I see no issue with us achieving the November deadline this year. That was all I wanted to say on the plan, but happy to take any questions or comments. Thank you.
Okay, thanks, Pauline. That's very useful clarification around the timescales. And as Marie says, it didn't cause us any particular problems that we were technically late in signing off the accounts last year, so we should be okay this year. Councillor Hannah.
Thank you, Convener. Could I take you back to page 98 and Exhibit 1, materiality? I wonder if you'd like to say a little bit more about the figures that have been chosen there. Members of the public might well think that a trigger point of something less than 4.3 million might be reasonable. It does seem like a very high figure. Could you say a little more about why that's the choice?
Pauline.
Yes, certainly. So that is a standard auditing calculation that we carry out every year as part of our risk assessment. And you'll see that the performance materiality has been set at 70% of the overall materiality. And we have a range that we can choose between. Typically, it's between about 50 and 70% that we select. 70% is at the upper level, and that just reflects the risk for the body, and also reflects on the quality of the controls the body has in place. And for the IJB, a lot of the figures come from the Health Board and the Council. So we obtain lots of assurance around the robustness of those figures from the auditors of both of those. And obviously I'm the Council's one. So that reduces the risk of there being a misstatement there. Also, we look at the history of prior year errors. So in a body such as this one, we don't have a history of there being errors or misstatements in previous years. So again, that reduces the risk of there being any. Essentially what that does is, if we reach that point, it indicates to us that there might be other errors in the accounts that would tip the level of error into the overall materiality. And the overall materiality figure is the important one, because that's the one that determines whether I can give a true and fair opinion on the accounts about them not being a misstatement that's material. However, I take your point, it does feel like quite a high figure, but just to give assurances that the reporting threshold, the 240,000, we would identify any errors that exceed that amount and would bring that to your attention. But the overall materiality is the one that matters, because that's essentially the one that allows me to sign off the accounts and confirm that they are not materially incorrect. So it's essentially an auditing terminology. I hope that explains it.
Yes, it does. Thank you. And it's also reassuring that you're saying that this is auditing previously robustly audited accounts.
Okay, thank you. Any other questions or comments? Okay, we're happy to note that report. Thanks, Pauline. Move on then. Item 9 is the Strategic Risk Register. Marie.
Thank you, Chair. This paper provides an update on the IJB Strategic Risk Register. No new risks have been added to the register since the last version presented to the then Audit Committee on the 15th of November 24. There are currently 9 live risks recorded in the register. 1 is considered very high risk, 7 are high risk and 1 is medium risk. The committee have been asked to consider and comment in the high-level summary, consider and comment in the detailed strategic risk register, and note the ongoing work in related to changes proposed and reported to the Audit Committee in November. As previously reported, a risk workshop was held by the HSCP Extended Senior Management Team, partner risk managers and officers in August 2024. The key outcomes and outputs from the workshop are attached again for information at Appendix 3. The recommended changes and focus reviews will take place over the next 3 to 6 months with a view to implementing the updated IGB Strategic Risk Register as far as possible from the June Committee. Pending the updates and proposed changes, each current risk will continue to be reviewed regularly and in detail. A number of updates have been carried out, and I'll just set out a few of those, starting at section 4.5. So for strategic risk, 1, financial sustainability. Controls have been updated to reflect the latest position in relation to the update of the integration scheme and in relation to ongoing work to close the medium-term financial gap. Strategic risk 2, governance arrangements, and strategic risk 5, assurance. Again, our newly established IGB for Performance Audit and Assurance Committee, there have been updates provided in relation to those updated arrangements. For strategic risk 4, capacity and infrastructure, in relation to the finalisation of the integration scheme, and further control 5 in relation to community hospital master plan. Although capital funding is not available at this time, discussions continue in relation to the future planning in this area. For strategic risk 7, host systems transformation, a number of updates are noted in the review notes section in relation to further control requirement actions, including primary care governance, set aside activity data, prison healthcare, transformation planning and future capital planning. For strategic risk 8, resilience and business continuity, a current control has been updated in relation to our emergency and incident response. And finally, for strategic risk 9, regarding primary care sustainability, note that the current risk score has been changed from 10 to 15, which is still high risk, following a review of the risk by NHS Forth Valley, and it should be noted that a further focused review is planned and an update will be provided following that review. I'm happy to take any questions on the details of the report. Thank you.
Okay, thanks, Marie. It's always a bit alarming to see a very high risk, but I think just financial sustainability, we all know the risk that's there, so that is realistic, if a little alarming, and that's, I think, where we have to be right now. Any comments, Councillor Hannah?
Yes, and obviously financial sustainability is our biggest concern at the moment. But I wonder if you could say a little more about the primary care sustainability, because that increase, that risk that's in there is concerning many members of the public, and it's something as a councillor that I probably get the biggest concerns raised with me about.
Okay, Tom, can I bring you in on this one?
Yes, you can. Thank you very much for through yourself, Chair. Thank you very much for the question, Councillor Hannah. I'm kind of glad to be at the opportunity to try and clarify some of this. Primary care remains a high-risk situation, and I think members, have been variously briefed in recent times to explain some of the major challenges around that, particularly at the workshop about a month ago. What you're seeing here is a reflection of us having to kind of reevaluate what we are describing more accurately in terms of the risk, rather than the score that existed before and how it was being described. And the reason for that is that we realised that in many ways primary care was being described in relation to organisational risk in the same way as, say, a hospital would, or a ward would, or any single institution. But in fact, of course, it is a much more complex arrangement of primary care with a large number of independent businesses whose business is deeply embedded into our institutions in terms of reliance and public health. But because of the way that it previously was looked at, it was trying to describe something with so many different parts to it as a single entity. So what we have done is kind of reevaluate how we are describing primary care. So presentationally, that of course presents it as a higher risk than it had previously been presented. But in fact, this presents it more accurately in relation to the current knowledge we have about its sustainability, and whether that be financial sustainability, workforce sustainability, demand sustainability. So this process was a redress of what otherwise was an unhelpful way of trying to describe the risks around primary care and its sustainability. I'm going on Monday morning to the NHS SLT with a paper on primary care sustainability and outlining how our new risk analysis works in relation to primary care, and so that they become a bit more familiar with how its distinctive parts. And then from that, we're also going to the NHS board, and we'll be coming back to the IJB in exactly the same way to describe all of this and how this works. So I'm not in any way, Councillor Hannah, diminishing, as you would know, the risks around about primary care, but in many respects, what you're seeing here at the moment is presentationally a redress rather than a sudden lurch towards greater levels of actual risk. They do remain very high, or high, in this matrix.
Thank you. Thank you, Convener.
Okay, thanks for that, Tom. Any other questions or points on risk? We're happy to note the position. Okay, thank you. That takes us then to item 10, which is the annual governance statement. Marie.
Thank you, Chair. This is the annual governance statement improvement action report, which is a standing item on the agenda and provides an update on progress to implement a range of improvement actions identified through annual governance statement and from various internal and external audit report recommendations. The committee are asked to consider and comment on progress report and improvement actions, and I'll set out some of the key points. At 4.3, in relation to the integration scheme, since last reported, Falkirk Health and Social Care Integration Scheme has been approved by NHS Forth Valley, Falkirk Council and the IJB. The integration scheme will also require to be approved by Scottish Government, and the committee will be updated when this approval has been confirmed. In relation to the Ministerial Strategic Group self-assessment set out at 4.4, following previous work carried out in relation to this assessment, a review of previous findings and next steps will be agreed as part of a June 2025 IJB development session, with findings brought back thereafter. 4.5, for Audit Committee self-assessment, the IJB at their December meeting agreed updated governance arrangements and updated committee arrangements, including terms of reference. This finalises the action in relation to the Audit Committee self-assessment, which has now been noted as completed. For other internal and external audit actions, a number of actions in the appendix are now marked as complete and will be removed for the next report accordingly. Regular reports will continue to be provided to all future performance audit and assurance committees, and I'm happy to take any questions on the content of the paper. Thank you.
Okay, thanks, Marie. So this will remain a standing item so that we continue to monitor the progress that's been made, and it seems like there's been a fair amount of progress with a few items able to be signed off. Any comments or questions? Councillor Hannah? No? Okay. Everyone happy? Okay, thank you. Item 11 then relates to the chairing and vice chair arrangements for this committee. I'll pass over to Jim.
Thank you, Chair. This report asks the committee to nominate members to the chair and vice chair position of the Performance Audit and Assurance Committee. This will then be presented to the IJB for approval at the meeting in March. The committee terms of reference note that the chair and vice chair will be IJB voting members. Whichever constituent party holds the chair of the IJB shall not hold the chair of the Performance Audit and Assurance Committee. With the appointment of Mr Johnson as chair of the IJB from 1st of May, we are now required to change the chairing arrangements. So I ask voting members to nominate to these positions.
Okay, thanks, Jim. So the chair of the committee then would have to come from Falkirk Council. Is there a nomination?
I think that leaves it down to Jim Flynn and myself, so I'll nominate myself. I've had discussion with Jim previously, and he's not at this stage keen to take that up.
Okay, thank you, Councillor Hannah. And in terms of vice chair, Stephen, I think that means you're het.
Yeah, that's fine, yes.
Okay, thank you. We're happy to agree that then for submission to IJB for approval.
Agreed.
Okay, thank you. We're getting through things quite quickly, thank you, folks. Item 12 then is the revision of the clinical and care governance framework, and I'll pass to Nicola.
Thank you. So this paper presents a revision of the Health and Social Care Partnership Clinical and Care Governance Framework, and all revisions to the document are noted via track changes, so it's easy for committee members to see the proposals. The current framework was developed following the establishment of the IJB in April 2016 and approved by the IJB in 2018. So given the time that's passed and the recent developments relating to the governance structure, a review of the framework. The revised framework does acknowledge the recent approved changes to the IJB governance structure and notes that this Performance Audit and Assurance Committee now provides IJB with assurance in relation to clinical care governance matters. The revised document is a framework where, rather than the IJB providing assurance to the partners, the IJB will gain assurance from partner organisations relating to the services which they commission from either. The Chief Social Work Officer, who's on the call today, has reviewed the updated framework and she's in agreement with the proposed changes. And it's proposed that the amended framework will also be presented at the NHS Clinical Governance Committee for comment by submission to the IJB. So in conclusion, the committee are asked to agree the draft framework for presentation to the for IJB approval following agreement from the NHS.
Okay, thanks, Nicola. Yeah, it was very helpful to have the changes tracked so we could see exactly what the amendments were there. That made it easier than comparing two different documents. So I think from my perspective, it seems like a sensible update and just puts everything into line with the new arrangements we have in place for governance. Members have any questions or comments?
I just wanted to say the same thing. It's very helpful to have the changes tracked, because I would have had to dig out the old version of it, and that makes life so much easier. And the changes do appear to be all relevant and sensible.
Okay. If there are no other comments, then are we happy to approve?
Agreed.
Okay, thank you, folks. Item 13 then is the duty of candour annual report. I think Sarah's going to take us through this one.
I am, Chair. Thank you. Good morning, everybody. All health and social care services in Scotland have a duty of candour. This is a legal requirement, and that means that when unintended or unexpected events happen that result in death or harm, as defined in the legislation, the people affected understand what has happened and receive an apology, and the organisations learn how to improve for the future. An important part of this duty is that we provide an annual report about how the duty of candour is implemented in our services. Falkirk's Duty of Candour annual report is attached at Appendix 1, and that's published every year in my Chief Social Work Officer report and routinely reported to the Integration Joint Board. The NHS Forth Valley Duty of Candour annual report is attached at Appendix 2, and both are with you today for consideration and comment. Section 3 of the cover report provides background to the duty of candour, how and when it's activated, and the responsibilities that it places on organisations. Section 4 highlights that the Falkirk Council Duty of Candour report was approved by Falkirk Council at their meeting on the 12th of December in 2024 and was also presented to the IJB on the 31st of January 2025. Between the 1st of April 23 and March 24, there were no incidences for Falkirk where the duty of candour applied. Importantly, the reporting template asks organisations to outline how we have made sure that our staff understand their responsibilities and to provide reassurance that we have systems in place to respond effectively. In Falkirk, we have developed a number of different ways of raising awareness and of the regulations to ensure that our staff know of their responsibilities and how to notify when criteria has been met. Our learning review process and guidance and our complaints procedure reference organisational duty of candour, and our reporting template is being created to ensure the consistency of reporting across services. Duty of candour is referenced where relevant during our training programmes, and the approach that NHS Forth Valley takes to provide assurance around duty of candour processes is very similar, and that annual report is attached in full at Appendix 2. Section 5 of the cover report notes that NHS Forth Valley consider organisational duty of candour vital to the provision of safe, person-centred and effective healthcare. During the reporting period, there were 11 incidents where the duty of candour applied, with a further 24 reviews still underway where duty of candour has not yet been established. These duty of candour reports seek to provide assurance to committee of the arrangements in place, and Appendix 2 outlines details of the incidents managed in accordance with the duty at NHS Forth Valley. All reviews were undertaken robustly in accordance with the Scottish Government framework, ensuring communication and engagement with the patient and relatives to ensure that they remain the absolute focus of the review, and that's of critical importance. Chair, this report is for comment and noting, and I'm happy to pick up questions. Thank you.
Thanks, Sarah. So do we have questions or comments from members? Roger?
I'm just wondering how many, well, we've done any research on how many staff or the proportion of staff who have seen the 7-minute briefing or any of the information and aware of the duty of candour. Have we got any feedback on that? So, Sarah?
Not to hand, Roger. I think the point you're making is the question that we ask ourselves around all of the training and the opportunities that we make available to our workforce. It's the so what question. What difference does it make? So in terms of numbers, there's an expectation that all of our staff across social care services would be engaging with the awareness raising we have around duty of candour, but actually testing out the impact is always more difficult. But that's certainly something that I can explore in a bit more detail with our learning and development manager. Thank you.
Okay, thanks, Sarah. Any other questions or comments? Okay, thank you for those reports. Move on then to item 14, which is the out of hours update. I think we're going to start this item with a video. So I'll ask Jim to cue things up for us.
Hi, my name is Wanda Campbell. I work as a personal assistant and I live in the Falkirk area in Polmont. I recently used the out-of-hour services for my daughter and I'm here to tell you the story of how that went. Back in November 2024, my 20-month-old daughter at the time was unwell. She was unwell in the preceding week. She started to have a cough and it sounded really, really bad, but nothing like the first weekend in November when
Apologies, having a slight technical issue with the sound. We'll try again. Yeah.
Hi, my name is Wanda Campbell. I work as a personal assistant and I live in the Falkirk area in Polmont. I recently used the out-of-hour services for my daughter, and I'm here to tell you the story of how that went. Back in November 2024, my 20-month-old daughter at the time was unwell. She was unwell in the
We seem to be having a bit of feedback. Okay, hopefully that's fixed things a little. That better. Bear with us just a second, folks.
Hi, my name is Wanda Campbell. I work as a personal assistant and I live in the Falkirk area in Polmont. I recently used the out-of-hour services for my daughter, and I'm here to tell you the story of how that went. Back in November 2024, my 20-month-old daughter at the time was unwell. She was unwell in the preceding week. She started to have a cough and it sounded really, really bad, but nothing like the first weekend in November, when the symptoms really worsened and it was a really chesty, really mucousy cough, and you, as a parent, you really were at a loss as to what to do. She wouldn't tell you, you couldn't ask, you wouldn't, you were really at a loss, and you felt you needed reassurance, you needed medical advice, and really not knowing what options there were. I phoned 111. When I phoned 111 on the day, I think around noon, I was put through to a consultant who listened to the symptoms and advised that I would be phoned back by a clinician, and that should happen within 40 minutes. It didn't, but closer to the 40-minute mark, I received a text message saying that they were running a bit behind and they will get back to me within within an hour, as soon as they can. And shortly after, I did get a call back. This time, I think it was a local person who, upon listening to Abigail's symptoms, decided to book us in for a GP out-of-hours appointment in Stirling, and we got a time slot for maybe 3:30 that afternoon. So I think from when I called to when we were seen was less than 4 hours. So it was a super smooth and quick process, and really, really easy. Once we arrived in Stirling Health and Care Village, we made our way to the reception and asked where we should go. We found our way to the waiting room, and shortly, maybe within 10 minutes, we were seen by a very helpful Irish GP who took us seriously, listened to Abigail extensively. There wasn't really anything wrong, that the lungs were cleared, and we didn't get any medication that we had to give her on a regular basis. But we were reassured that it would just run its course and be okay. We were, I think, the fourth baby seen that day, so it looked like something was making rounds, and the GP knew what she was talking about. Maybe our visit was maybe 15-20 minutes. So from when we got to Stirling to when we left Stirling was probably less than half an hour. So I think one of the smoothest healthcare experience I've ever had. If it wasn't for the out of hours, my options probably would be GP the next day or emergency department, neither which seemed okay, neither which seemed to be addressing or alleviating any concerns I had about Abigail's health. So I'm really grateful that the out-of-hours service was there, that we were seen on the same day and reassured that everything was okay. I hope everybody has as positive experience with out-of-hours as I did, or overall as positive experience with the healthcare they access as I did. The GPs are doing a brilliant work. The nurses are working tirelessly, and everybody whom we've encountered during our experience was very friendly and positive and knowledgeable and showed us kindness, nothing but kindness. So thank you very much. It meant a lot for Abigail, and it meant a lot to us.
Great, thank you. We got there in the end, Jim. Thanks for that. Andrew, I'll pass over to you.
Yes, good morning, Chair, and good morning, everybody, and thank you for the opportunity to come and present the update for out of hours. And it was good to start with that really positive video, which really is is a good example and a good testimony of where the service is now at, and from where it was a couple of years ago. I acknowledge that the document, the report that has been submitted will have been read and reviewed by the committee. So I obviously won't go through that report in in a great detail, but what I'd like to do is just summarize that journey with a short presentation that has been put together. If that's agreeable to yourself, Chair, to share my screen just to talk through that presentation that has been put together. Is everyone able to see that just before I start?
Yeah, we can see that,
Yeah,
Andrew.
great. Okay, thank you. So this is just a summary of the timeline of the journey that out of hours has been on over the last couple of years. So in 2022, there was some challenges identified within the out of hours service, which led to a visit from Sir Lewis Ritchie and his team in October 2022. Some of the challenges that were found, give me 1 second, sorry, it's there we go. Some of the challenges that were found were around difficulties in recruitment into the out of hours service. There was a gradual and a loss of salaried staff within the service. There was a lack of engagement from local general practitioners. There was no dedicated management structure, and out of hours was split within the acute site. The rota fill for the service was very much reduced and was at a low level consistently. And there was also an impact on the well-being of the team for the team that were in post due to these challenges. So that then led to a focused piece of work with clear project management put in place to address the recommendations and the challenges that Sir Lewis and his team had identified. That was approved in November 2022. And then from that period on, there was a number of follow-up assessments, which included a monthly report going into Sir Lewis and the Scottish Government team. There was a further physical visit in June-ish of 2023, and then there was a final. Then there was another visit in March last year, 2024, and what Sir Lewis Ritchie found, certainly in the visit last March, was that he identified that there'd been some significant improvements made within the service, that of the 12 recommendations that had been made and the 12 action points that had to be addressed, over 90% had been addressed, and the remaining actions were actively being worked through and followed up on. And that included having a much more stable and resilient workforce in place, a good multidisciplinary team recruited and in place, increased engagement from local GPs who were then wanting to come and work alongside us and work within out of hours. We were also looking at addressing the concerns and the challenges we had in recruiting salaried GPs, and we were on the road to recruiting those GPs at the time of the visit. Pleased to announce that we have now recruited all of the vacant GP salaried hours, and that has further strengthened the team that is in place today. So following that visit in March last year, the monthly reporting was changed to quarterly reporting. And then in December of 2024, we received formal confirmation from Sir Lewis that he was satisfied that we had actively met all the actions that he had identified that had to be addressed, that there were significant improvements and the service was operating a much more robust and stable and resilient service. And as such, he was advising that he was going to recommend and propose to Scottish Government that the scrutiny and escalation status of the out-of-hours service was lifted, and that the service would return to business as usual operations on that basis. Just wanted then to share you some key performance data, which evidences the journey we've been on and where we are today as a service. So over the service has always recorded periods of times when, and it was previously known as periods of escalation, operational escalation, where the demand on the service was deemed to be greater than the team's ability to deliver it within a reasonable timescale. And as you can see there from the data, that in 2023, the number of times the service were operating under that status was quite consistently high throughout the whole year. There was definitive pinch points in that, which included the Christmas period, the Easter period, but also most weekends the service really struggled to operate and meet the demands within a reasonable timescale. But as the service improved and increased the staffing levels and increased the leadership within the service as well, then over 2024 we saw that significantly reduced down, and we've now developed a framework within the wider OPAL framework, and we now record the periods of when we operate within red and purple. And as you can see there from the graph, those periods have significantly reduced over 2024 and continue to remain very low in the early parts of 2025. This is just a breakdown of the number of cases that out of hours sees on an annual basis, and you can see that consistently the demand for out of hours is well over 67,000 patient contacts a year, and that is continuing to grow over 2023 and 2024. And the early Q1 data for the Q4 data, which is the early part of 2025, would suggest that those numbers continue to increase into this year as well. So the demand for out of hours service continues to grow year on year. This was just to give you an indication of the top 10 conditions of what patients present to out of hours with, which is in line with what we'd expect for the out of hours service to be used for the urgent medical care that patients feel and cannot wait till their own GP practice is open the next time the GP practice is open. And as you can see, it's fairly consistent year on year as to what those conditions are as well. I guess the one I really want to focus on, just to sort of evidence and support what Wanda said in the video there, was that the timescales in which we're able to take a patient through its journey from the point which they are first referred to our out of hours to the point where they can be discharged from the service, is, you can see there that, you know, in both 2023 and 2024, we were fairly high, 92% in seeing all cases within 4 hours. As a service, we aim to see all patients within 6 hours because we think that's a reasonable timescale. And as you can see there in 2023, and it was 97%, and then we've increased that to 98% across 2024, and we continue to operate at that as a minimum level. And in some months, we are seeing 99% of all patient contacts within 6 hours, which is further evidence that the resilience and the stability of the service and the team that we now have in operations on that basis. And that's just a final slide on demonstrating the rota fill. Now that we have a fully staffed salaried staff team, we are operating with a rota fill of 95% plus every month. We still have a small team of sessional GPs which complement the service, which helps cover things like sickness and holiday periods for the salaried staff, etc. And that helps us achieve those outcome performance targets that you've just met. And we've already seen the video, so I'll open it up for questions now, Chair. And again, thank you for the opportunity to share that with you.
Thanks so much, Andrew. This is a real good news story. Tremendous improvement over 2 years, and it's great to see us up to not 99% of patients seen within time. That's pretty remarkable given where the service was a couple of years ago. So well done to everyone involved in making that really transformative change for our patients. Other questions or comments? Councillor Hannah.
Thank you, Convener. Yes, and obviously we're all impressed by the improvements there. But I did want to ask a question about the video we saw. And that particular person was very happy, but that particular person was also able to lift her daughter and drive from Polmont to Stirling to see a practitioner. There are many, many people for whom that would not be an option. What would be the situation in those circumstances?
Thank you for your question, Councillor. So as an out-of-hours service, the patients coming into one of our sites is just one option of treatment that is available to the patients that we see. One of the other option for patients who are, as you say, are not able to live there or to themselves come to one of our sites is that we have a team of drivers who can, if it's relevant and suitable and appropriate for the patient to travel, can go and pick a patient up and bring them in to see us. Or our clinicians can go out and do home visits and do go out and do home visits for patients that are assessed that it would be unsafe or they are not well enough to leave their home to see a clinician. So we do a number of home visits each and every day, particularly over the weekends. Our home visits on any given Saturday, the number of home visits we can fulfill can be anything between 15 and 20 home visits. So it is an option. Not every patient, if patients are not able to travel to us, we can go to them.
And is that all from a base in Stirling? Or is there more than one base? No,
we operate from 2 bases. So we would probably see our main base as our site at Forth Valley Royal Hospital, and Stirling is a second site. And clinician from either site could go out to do those home visits. And the senior clinician on the day would make a judgment call as to which clinician was best placed to go out and fulfill those home visits.
Thank you, Convener.
Okay, that all makes sense. Thank you, Andrew. Any other questions, Roger?
Thanks, Chair. I was just wondering, this does seem a good news story, and can what we've learned here be transferred to other parts of the partnership which may be struggling?
I would say absolutely. Roger. The work that we did wasn't, I would say was generic improvement work. And I can only represent the work and what we've achieved within out of hours. But I know Gail's got a hand up, so I'll hand over to someone who's better placed to answer that question, probably Roger. But thank you for your question.
Yep, come in, please, Gail.
Thank you, and thanks for the question. I think it's a really good question in terms of where we see improvements in what area, to understand what's driving those improvements, to make sure that we can spread that across the whole partnership. So I think we have seen a really dramatic improvement in out of hours, and real credit to the teams that have been involved. And I think that combination of having a really strong leadership across managerial and clinical, and that the excellent working together across that managerial and clinical has really made a big difference. I think, as Andrew said, in terms of taking that improvement lens, in terms of thinking about how we can make improvements, and I suppose in terms of thinking about good, strong leadership across the partnership, you'll be aware that through our structure review, that's one of the things we're aiming, what we have aimed to put into place, and taking that quality improvement and wider improvement approach is something that's also spread. So it's really important that we give the time and space for colleagues like Andrew and the team to come and share the good news stories about what's working well and what's led to that, so other teams can be inspired and take on board some of the learning as well. So I think it's been a really challenging piece of work, but I think the evidence and the data that Andrew showed today has really showed the improvements that have been made through strong leadership and that improvement lens.
Yeah, it's a great point. Thank you for that. Where we do have good practice, then we should be looking at how we learn from that and spread it. That's a point well made. Okay, if there's nothing else, I'll just say thank you to Andrew and the team there, and congratulations again on that great outcome.
Thank you, Chair. Thank you, everybody, and I wish you well for the rest of your meeting. Thank you.
Thank you. Okay, item 15 then is the assurance template for the IGB. I'll pass to Marie.
Thanks, Chair. The new terms of reference for the Performance Audit and Assurance Committee were agreed by the IGB at its January meeting. It was recognised when updating the IGB and committee arrangements that assurances should be given to the IGB in the work of the committee on an ongoing basis. Previously, this was done by presenting the minutes of the Audit Committee to IGB and via annual assurance reports. However, IGB members felt that an additional ongoing assurance would be more appropriate moving forward. An assurance template will now be completed for each committee, with a final assurance report each year to summarise. Appendix 1 is an example of the first template of this nature and will be the format included in future papers, along with a short covering report, and will then be remitted to the IGB immediately following each committee. I'm asking today for the committee to approve the format of the assurance report to the IGB, and also to consider whether the committee are assured by the reports and discussions undertaken today, and confirm if there are any matters which require to be highlighted to the IGB accordingly via the assurance report. Thanks very much. I'm happy to take any questions.
Thanks, Marie. Yeah, I think this is a sensible way to move ahead, rather than simply sending minutes which don't always tell the full story of what happened. This allows us to consider as a committee whether we are assured by what we've heard today, and if there are any particular issues that we think should be flagged up to the IGB. Given it's the first time we're doing this, we can try it and see what happens, and if there is need to refine or change as we go, then there is always the opportunity to do that in that spirit of continuous improvement. But I think the approach makes perfect sense to me. If other members have questions or comments?
Happy to agree.
Anne-Marie, can I bring you in?
Yeah, it was just a very minor thing to add to the attendance when the internal audit and external audit are in attendance at the meeting.
Yeah, that would make sense. Thank you for that. Okay, are we happy to approve the template?
Agreed.
Okay, great. So in relation to today's meeting, there's a number of actions we've highlighted as we've gone through, but is there anything particularly that committee members would like to see highlighted in the report that goes back to full IJB? Nothing beyond points we've already made in discussion. Okay, great, thank you. We now come to, oh sorry, there is a hand up, Gail.
Yeah, I was just going to highlight the template also asks the questions, do committee members feel they're assured by the information that's been considered today? And I just wondered if members would want to take a view on that.
Okay, do we feel suitably assured in relation to the items we've discussed?
Yes.
Yes, I'm seeing nods from the voting members, so we'll take that as a yes, thank you. Okay, the remaining two items on the agenda we're suggesting that we take in private because they contain a number of very sensitive clinical and care governance issues. Is that acceptable to committee?
Yes.
Yeah. Okay, so we'll take a 5-minute break just while we close off the live stream and just make sure that we are running in private. So we'll come back in 5 minutes.